Hi, good day. Welcome to Arrhythmia Academy. We're so excited today to have a very, very special webinar on procedural differences between women and men. And I'm so excited that all the faculty members said yes to coming on to the webinar to talk about their experiences about a how-to about procedural differences between men and women patients. So my name is Dr. Elaine Y Wan. I'm assistant professor at Columbia University, where I'm also the director of electrophysiology research. Today, our panelists include our esteemed Dr. Andrea Russo, who really needs no introduction, as she's the past president of the Heart Rhythm Society. She's professor of medicine at Cooper Medical School, and well, director of cardiac electrophysiology and arrhythmia services. We also have Dr. Yong-Mei Cha, who also needs no introduction. She's the director of cardiac device services and professor of medicine at Mayo Clinic. And finally, we have my good friend who I've come to know very well, Dr. Tina Baykaner, instructor of medicine and cardiac electrophysiology at Stanford University. I think we're going to have a great discussion today, a really little known topic about how to approach the female patient about implantation of devices. And I think we really have a diverse panel that will be able to share their personal experiences about implantation in female patients. So first, let's talk about the differences in the women and female and male anatomy. So for one, we can see on the slide here is that the chest size of the men and the women can be very different. Also for the women, there's the anatomy of the breast, which may include the breast itself, as well as the axillary tail, which may affect the placement of the incision and how the generator is placed later on. Also women, because of their breasts or our breasts, there is the need for placement or wearing of a bra that may be different day to day in the effect of the garments that they wear and also physical appearance. So these are new things or things that we should consider when we place devices in female patients. Our next slide shows that there are choices for device and location of placement. On the left-hand corner here is actually a blog from a patient who talks about her experience with having a pacemaker. It's called Cœur crevé, which means basically my heart has burst in Belgian or French. And basically she experiences or documents her experiences with having her device and how that affects her daily living. And for example, the bra strap along with where the pacemaker is. The other choices for device location may vary, including the subcutaneous defibrillator, where it may be the left below the left axilla. Of course, there's also the loop recorder we're going to talk about later too amongst our panel about where is the optimal placement for women. And finally, there's also new leadless devices, wireless devices, such as the Micra, and other upcoming leadless devices where none of the generator can possibly be seen subcutaneously or externally. So the approach in the women may be different. And here's an example from anatomy, which I'm sure we all remember from Anatomy 101. And it shows the breast as well as the adjacent vascular structures. And your venous access options, as we all know, may include the cephalic, axillary, subclavian access. And they may, that access may affect where we ultimately put the generator, as well as what access we actually choose for our female patient. And later on, we'll talk about the generator pocket locations, whether or not subcutaneous, subpectoral, whether or not a flap may be needed. And usually, sometimes we may call our colleagues from plastic surgery to assist us with that. So I'm going to start off some questions for our esteemed panel. And I'm going to start off with Dr. Russo. What is your approach to the device placement in the female patient? And what are some of the considerations you make preoperatively?
Yeah, thank you. Thank you, first of all, for putting on this webinar and inviting me to participate. It's great that we're talking about this. I think it's under people don't think about it as much as we need to. So actually, in terms of access and devices, I usually, if patients don't need CRT or don't need pacing, I do consider and I do talk to patients about either a totally subcutaneous device as versus a pectoral device. And some women as well as men may have concerns about body image and might want something more concealed or more private. And the subcutaneous device might be something I might consider more highly that gets out of the site of visualization for the general public and it affects things differently. In terms of access, I typically use cephalic vein access in all patients, and that's more because of long-term lead issues being lower with cephalic vein. So if there's a good cephalic vein, I'll put 1 or 2 leads in there depending on what type of device they have if they get a pectoral device. In location, in the pectoral region, most patients, I do go with subcutaneous. I think in a very thin patient or someone who is very concerned about the appearance or the bump from the device itself, you can consider submuscular. I think, some people have, not that many electrophysiologists, I don't think, use submammary approach, but that is, an alternative approach for some patients who are more concerned with, with the device location and being more concealed. But, for the most part, cephalic vein access for men and women. But I do think of where the generator is and where, they might have concern with certain clothing and bra straps and things like that. But sometimes, you're over that area and you can't completely avoid it.
And Dr. Cha, can you share with us your experiences with your female patients about the considerations you make when you approach them for device placement?
Sure. I completely agree with Andrea. I think when I see a patient in a clinic and of course recommend a patient to have any device, either pacemaker or ICD or CRT devices, based on the guideline recommendation, I always show the patient the device size, the shape, and the options. And also I show the patient where the device is supposed to be, usually about a finger below the clavicle. Most patients put on the left side. And then essentially patient knows where the device is going to be located. And then they have option to choose the shape of the device, the size, the thickness. So they pretty much know, what they are going to anticipate when the device is put in. I think that's good for the patient education. And then have some idea the device is going to fit to that patient need or anticipation. So usually I tell the patient, we make an incision 1 centimeter to 2 centimeter below the, for example, left side, the left clavicle. And I tend to make the incision a little bit more medial, and with the lateral side, not over the pectoral delta groove, because I think that's pretty much the bra, I think probably will be in that location. So I try to be a little bit medial. So in this way, when patient move the arm, it's really not conflict too much in that area. So when the device on the medial is more stable, not impacting the joint movement, that's another thing we need to think about that. Of course, there's a benefit if Andrea mentioned about the cephalic, right? So if you do cephalic or completely extrathoracic approach, then you definitely no pneumo, right? No pneumothorax. That's a good thing. But the device usually is more on the lateral side in that case. But it really depends on each individual patient. But the most common, I put the device more on the medial side and just 1 to 2 centimeters below the clavicle.
Great, those are very insightful comments about medial versus lateral, and of course adjustments according to the patient's chest and also their breast, whether or not it would be cosmetically appealing to them versus practicalities of their garments that they wear. Dr. Baykaner, if you could, Dr. Cha talked to us about the different incisions that are possible for a pacemaker. In your experience, can you talk a little bit about loop recorder? Because we were just talking about this with two of my female fellows actually. For women, having the loop recorder, there are some hindrances. For example, like the mammogram or the bra. Where is the best place to put it so it's sort of hidden, but also can get good signals? What has your experience been?
That's a good question. I tend to place them a little bit lower. First, I have moved to mapping for a relatively better signal before implanting the loop, especially if I'm planning on implanting at a less traditional place. So put 2 ECG patches and then make sure it's still getting a good R vein amplitude. And if I have the luxury, I have them wear their bras and make sure that where I'm hoping to put it is not at an uncomfortable place for their other undergarment. And if the signal is reasonable, I try to move them lower. Recently, I had the pleasure of encountering a patient, an adult congenital patient, who was implanted a loop in an axillary location by the pediatric group in Boston. It's something that I've never seen in adults. I actually tried to convince the patient that she doesn't have a loop recorder because she had absolutely no incision nothing on the chest X-ray in the AP view. But that also gave me a good idea on where it could be completely hidden. That is commonly practiced by our pediatric colleagues. That could be an option, and especially thinner people who absolutely don't want it anywhere visual. It had great sensing, and I noticed that's a good option as well.
And can you comment on your approach for pacemakers or defibrillators? What are your experience with the incision sites?
Yeah, I agree with Dr. Cha a lot. Women tend to complain or verbalize more that the generator eventually moves or migrates towards their armpit more than men, probably because of the higher amount of fat tissue and the loose tissue in there. So I try to move it more or make the pocket more medially to avoid these kind of eventual migration. I like using ultrasound for access in general, which gives me some freedom in making the access independent from where the pocket eventually is, because I can get access with the ultrasound wherever there's good visualization, but I can make the pocket independent from there where I think it's the most convenient, most desired by the patient, and then retain the wires through that pocket. I tend to choose smaller generators or manufacturers with the smallest generators, maybe with less longevity of battery. But if it's a very thin patient, I don't think they would prefer a much bigger generator with more. I think it's fair to ask the patient what their preference would be. But if they have no preference, I tend to choose a smaller generator manufacturers for females. And I ask the patients about their incision preference. Some feel very strongly about having a vertical incision rather than a horizontal incision, which is more common that we do, so that it can hide in a t-shirt with its straps vertically. And they sometimes specifically point out to me where exactly they want the incision. So I think it's a good idea to ask them if they have a strong preference about the incision.
Sorry, just on that, because I agree totally with the cephalic vein approach. Your incision to get the cephalic vein will be more lateral, but what 2 things I do to prevent the generator from, I make my pocket more medial. And I think that's important actually for both, men and women. And you don't want it to, climb up too high. So not just medial lateral, you don't want it to be too high up next to the clavicle, but also make the pocket more medial than where your incision is. And on top of that, I always use with ICDs in particular, because they're heavy and they can move, as was already brought up by the other panelists. I always put a suture, a silk suture in the little suture hole that's in the generator to prevent it from moving too much, not too tight that it doesn't have any motion, but that it doesn't crawl all the way over to the axillary region. But those are all really good points.
Would any of you use like longer wires, pacing wires, so that there's more space so that the generator will hang lower in the pocket? Is that something that you've ever considered?
The generator, and just Andrea emphasized that. I think because of the breast, right? So the generator tends to drop. In the supine position, it's different from standing position. So in this way, tag the device on the pectoral muscle is very, very critical. Sometimes I not only put one, I put 2 sutures on. If you have even one hole, you put the 2 sutures, is really want to hold the generator not to drop down. And then also sometimes because the subcutaneous tissue is so loose, and then some patients even say when I, sleep on the left side, my device stand up. Sometimes they flip, because it's too loose. So the tissue, too much tissue in there. So I think it's not purposely tweet the device, but the device can flip. So that's another reason, we really want to fix the device in the position. So that's why I intend to put the incisions really tend to be higher rather than drop into the breast. So
Okay.
that's very, very important for female gender.
Yeah, those are great points. Something that I've always told my fellows is that I'm always interested in making a small incision. One, because it's less to close, so it's faster closing. But I also like it because I tend to do like a sock method where the incision can be small, but then you can expand the pocket inside. So therefore, it's a smaller wound. So those things I tend to be more cognizant of when I have a smaller size patient and in women. So we're going to move on to the second question, and there's so many questions pre-op and intra-op and post-op, which is why the seminar is divided into part 1, part 2. So just to close out for our part 1, intra-procedurally, when you're performing the procedure, how do you prepare the patient for surgery, and what is your approach intra-op, looking at the patient anatomy that may be different for women compared to men? Dr. Russo, do you want to start us off? Like, for example, for me, when I have a female patient and we're prepping her, for example, if her breasts are very large and pendulous, I like to tape it so it doesn't drag to the side, so the incision goes laterally, because just like Dr. Cha says, when she should stand up or in her normal day, the day activity, it would look differently. So I like to prep the patient as if it were like her daily life, instead of supine, like you talk about, when gravity really drags the skin and the breasts sideways sometimes. I don't know if any of you have had any of these little tips or tricks that you consider for patients who are women.
I think that's actually a really important point, because what we're doing in the lab, they're lying supine, and then we do also sometimes we'll tape breasts, and in particular I find that even more important for the subcutaneous ICD, because we're often using landmarks, and I do try to, for the subcutaneous ICD, I do try to mark that ahead of time. And then just do a quick, fluoro image to make sure you're as high or as you're or where you need to be, and you're not too low, down by the diaphragm. But it really distorted image for the subcute. Also, if you tilt them a little bit, also to when you make your incision, you want to make sure that you're getting posterior enough. With a generator, you don't leave it, too anterior. So I think things get very distorted when you start to, tape up breasts and motion like that, but also for the pectoral location, I think that's important also, as you mentioned.
Dr. Cha,
Yeah.
within the procedure, are there certain changes that you make or things that you're more cognizant of for the female patient?
Yeah, I think I don't often really have to put the tape, for the supine position if it's a pectoral, approach. Subcu ICD, of course, probably we have to. That's different. But for the infraclavicle location, I think it's just for the patient with the large breast. One thing, especially with my fellow working together, it's always make sure the incision is above the breast. sometimes the breast can be moving to the clavicle. So you really push down a little bit and make sure the incision and the subcu pocket is not in the breast. So that's very important. So otherwise we will be in trouble, right? Infection and then breast issue, other issue. So I think make sure the incision is clearly in the subcu tissue panel, not get involved in the breast.
Okay. Dr. Baykaner, and you during your procedures, what are some things that you've encountered intra-op that you might consider for the female patient?
One thing that hasn't been mentioned is that I find that the landmarks get a little more blurry in females after we prep and place all the towels, probably because of the extra fat, subcutaneous fat tissue. So I pay a little more attention in women in marking the incision site before prep, before all the towels go in, so that we are not far off once we are prepped and we are assessing again intraoperatively. I do use the taping of the breast quite often, even for the pectorals, but marking of the skin incision site I find helpful in women ahead of time.
And I think to expand on some of the comments that were mentioned earlier, I think also the implantable loop, actually your landmarks, everything goes away once they have that little drape on there and you can't see anything. And we had one case that was actually implanted elsewhere, but came with this loop monitor that was also getting a lot of noise and bad recordings because it was floating in the fat, and but it was also very painful for the woman, because it was in the breast tissue, so she wanted it out.
Another thing I want to mention is if patient has breast implant, that's once in a while we encounter that patient, patient has breast implant. In that situation, if you see it's a difficult situation, you don't have too much, place to put the device, I invite plastic surgeon. So in that case, and then to make sure we're not get the pocket is not intrude into the implant. So that's very, very important for the female patient.
Great, those are great.
And that actually came up. We had a patient not too long ago, actually, who was very concerned about the cosmetics and actually chose a sub-Q ICD. And there, you could stay very lateral. You just have to make sure your incision is not anterior, so you're fully away from the breast. But it certainly, you could still use a subcutaneous device. Just watch where your incision is.
Okay. Great. Those are great comments from really 3 experienced implanters. And this will do it for our part 1. And because we have so many questions about implantation for devices in women, we will move on to the post-op and post-op care of devices in part 2. So stay tuned.